Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
So we're going to talk today about claudication, which sounds like a complicated word. It means, out of Latin, it means pain in your legs when you walk. And it's important for all kinds of reasons. One is your legs, of course, but also because it's kind of a keynote to what's going on with the rest of your body. So we'll go through this kind of slowly, and there's plenty of time for questions and answers. So don't just stick up your hand if you have something that you want to talk about, okay? So I have my little gizmo here, and the technology sometimes escapes me, but I like to start with this slide because it kind of reminds me of a lot of my patients, and as I'm getting older myself too. The legs, they're the thing. When they go, you go, and that is really very true. We're not talking about dying here. We're talking about living. Living's a lot tougher than dying in some cases. And when your legs go, your quality of life changes enormously, and really enormously. And also the legs are kind of the gateway to the rest of your body. When you don't maintain your fitness by using your legs, the rest of your body tends to go. And it turns out, if you saw the Wall Street Journal last week, that screening of your legs for plaque, which we're about to see all kinds of pictures of, is a very important keynote for heart disease and stroke. In other words, as we're going to do Saturday, and I'll talk more about Saturday a little bit later, we're going to screen for plaque in your legs and thereby perhaps tip you off to having heart trouble or stroke situations. So anyway, I kind of like this quote because it's very important. So we're talking about a disease that, as opposed to some of the lectures you're going to go to here, not everybody in the room has. But no matter how you got here, everybody in this room has hardening of the arteries or arteriosclerosis. It's called that because as the arteries get older, and these are the pipes that lead from the heart all the way down to the toes, carrying blood, okay, away from the heart. Veins, like varicose veins and so forth and so on, is not part of today's talk. Varicose veins carry blood, and veins carry blood back to the heart from the extremities. Arteries are the ones that carry it down, and the arteries are the one that produces the pulses, etc. So just so you remember, this is a normal artery. It's a nice straight tube. This one in particular happens to be one in the abdomen. It's called the aorta, and it comes down straight to the belly button where it breaks into two parts. It's nice and big and round, maybe as big around as a man's thumb. Okay, and when you're first born, it's very thin-walled, pink in color, and the inside is smooth and shiny and glistening without any plaque at all. As you get older, it develops hardening of the arteries. Arteriosclerosis is Latin for hardening of the arteries. And that is basically a thickening, not of the entire wall. The outside wall is normal, and it looks normal. When we pick up an artery that's filled with plaque and look at it from the outside, it's normal in appearance, looks great. The inside is this terrible corroded, calcified, which means bone-like, ulcerated, which means irregular plaque that builds up with wear and tear. Remember, your heart's delivering a pulse, just like a punch, every second or so, all of your life. And that punch travels through this system and produces wear and tear. If you add cholesterol, old age, smoking, and a variety of other things, you get more plaque than if you don't do those things. So don't get old. That's the main thing. If you do, all of us in this room are somewhat old. We all have some of this in our body, some more than others. It starts out, this is an autopsy of an 18-year-old Vietnam, unfortunately, died in combat. And on autopsy, you can see not a smooth, shining surface like the screen here, because literally that's the way a normal artery looks, but instead these yellow little elevated plaques, just a bit. So cholesterol already in this gentleman, perfectly normal, off to war, has this number of plaques at that age. Very, very common, normal aging. As you get a little bit older, you get this streaking effect. See these little ridges, okay, and then valleys and so forth? Those are actual plaques growing up into the arterial system. This might be in your 30s. This is way later. This is the aorta, that blood vessel in the belly that we were just looking at. It's supposed to be nice and smooth and shiny throughout, remember? All of this stuff is inside the aorta of this unfortunate gentleman. Here's the belly button, right leg, left leg. This is all plaque, and it looks very much like a decayed tooth. It feels like that too. It's got little particles, little bony little chips in it. So that's hardening the arteries in its latest phases. So, arterial disease, it start out with you go to the doctor, you're not quite sure what you've got. Maybe your primary care, your family doctor says, you know, I think you might have some blockages in your legs. You better go see someone like me, who's a specialist in circulation. They're going to start out with a history. Let's go to your legs, forget about your head, your heart, your arms for a minute. Just your legs. The symptom is claudication. Now, everybody has pain in your legs as you get older, right? Knee pain, hip pain, muscle pain. You know, everybody gets pain everywhere. One of my famous patients, Morris Hyman, the Fremont Bank guy, had the 10-30 rule, which I practice today. He said, you wake up in the morning at my age, he was in his late 80s, everything hurts. It hurts all over the place. This hurts, that hurts. You know, you go to the bathroom, you can barely make it. Everything is, he says, don't call your doctor. If you do, all kinds of bad things happen. He says, wait till 10:30. Okay? Whatever's left after 10:30, tell your doctor about it. Okay? But don't tell him anything that goes away before 10:30. So, claudication, pretty classic business. The patients say, you know, I never noticed I had any trouble with my legs until I went to Hawaii. And we had to walk in the airport from the baggage place way out to this endless terminal. And by the time I got there, my right leg, maybe the calf the most, but maybe in the thigh too, I had the worst Charlie horse I could imagine. It was really killing me. I could barely go any further. And I said, okay, then what did you do? And I said, well, I sat down. I said, okay, did it last? Did it last all day? No. It went away in about 3 or 4 minutes. But then I went up to get some candy. And on my way there, same thing happened. And when I rested, it went away. But I haven't walked very far. I mean, I'm not a walker. And the airport thing was the furthest I've walked in years. But when I get home a couple months later, now I go down to the mailbox. Same thing, a cramp, pretty bad, rest, goes away. Quickly, okay? A bad person with a bad back, they'll walk and get leg pain, but they have to sit down and rest for quite a long period of time before it goes away. Joint pain, same thing. Get a sore joint after a long walk someplace, a long shopping spree. The joint pain doesn't go away in 3 or 4 minutes when you stop walking. So it's very specific symptoms. That's what I'm listening for when I get referred a patient for possible circulatory problems. Rest pain is the next stage. The person says, yeah, you know, for the last couple of years, whenever I walk very far, I'd get cramps. But it always went away when I stopped, so I didn't care about it very much. You know, it went away. Anything that goes away before 10:30 or even later, don't tell the doctor. But now, it's not just when I walk I get pain. I can't sleep. I'm okay during the day, except I get those cramps when I walk, but that's okay. But when I lay down at night in bed, I get 2 hours, an hour and a half. Now it's down to about 15 or 20 minutes. My leg goes numb, gets cold, and my calf cramps up like crazy. That's called rest pain. It's very simple. During the day, gravity is helping pull the blood from your heart through these blocked arteries all the way down through these passages, and it finally makes it down to your foot, and your foot says, okay, I'm okay. But at night, gravity doesn't help. And that's just that little bit of difference of lying down compared to standing up. I wake up, my foot is killing me. Now, a lot of people wake up during the night for other reasons, like to go to the bathroom. Okay, and they notice, yeah, I wake up with pain, but I have to go to the bathroom anyway, so I go to the bathroom. By the time I get back, my foot's okay, and I can sleep for another hour or two. So it's a little confusing, but it's very specific when you finally, you know, do a little detective story. It's pain at rest with elevation that goes away quickly with dependency. And finally, the latest stages, and we'll look at these in a minute, are breakdown of the skin. We're all constantly traumatizing ourselves, especially your feet and legs. We're bumping into things, we step on something, the shoe didn't quite fit right, and with normal circulation, no problem. Heals up right away, you don't even notice it. But with poor circulation, you'll cut yourself, get a bee sting, coffee burn, something like that, and it doesn't heal. It's not like trying to grow grass without watering your lawn. You can't heal something without extra blood. It takes very little blood to keep your skin intact if it's intact. But you cut it, it needs extra oxygen, extra blood to heal, and so it won't heal. So we have a wound clinic here, and every week I see people who come in saying, you know, I've had this little thing on my foot or my hand, and it will not heal. And I'm referred to this wound clinic for a long-standing, non-healing wound. It turns out they don't have any pulses. They have no circulation. So that's the latest stage, ulcers. The rate of onset is important too. Rarely does vascular disease occur last night. Heart attacks do. Fine, I saw the doctor yesterday morning. Last night I had a heart attack. Common story. Because it's hard to tell about the heart, okay? But legs, most of the time, we don't see someone who was perfectly fine until this morning, and now he's got a seriously diseased leg that's about to fall off or develop gangrene. Usually there's a long story over several years of smoking, diabetes, getting older, cramps, not so bad, cramps a little worse, cramps after that. Finally, maybe an ulcer that doesn't heal, and finally a leg that's about ready to die in its entirety. So we go from claudication, rest pain, ulcers, and finally the onset is for all these things is slow. It's not something that you're going to complain of tonight and be in trouble tomorrow morning. Risk factors. You know, when I was in medical school, we used to think it was a joke because the professors used to say, take a family history. How old's your mother? How old's your father? Well, if you were 20, you could answer those questions, but if you were 70, you had no idea. Well, now you do. Most people in this room know exactly what their mothers and fathers are alive and suffering from or what they died of. And believe me, the more we know about genetics, the more that history is important. If your mother had breast cancer, pay attention. If your father had a heart attack when he was 49, and your uncle had a heart attack when he was 49, and another uncle lost his leg when he was 53, you better not smoke, okay? Go see your doctor, find out what your genes really are doing, and find out what your genetics are. So family history is very important. How many other people in your family had similar circulatory problems? Because it predicts your future very, very accurately. Smoking, everybody knows, I showed you the picture about smoking. It's, you know, it was in the early 60s when people said for the first time, we think smoking has something to do with heart attacks and strokes and so forth. And there were millions of people around the world said, you gotta be kidding. That's crazy. Okay, everybody smokes and only some people get heart attacks and so forth. And for a long time, you know, that made sense. If it's such a terrible thing, why doesn't everybody get it? And the answer is you have to add the smoking risk to other risk factors such as diet, exercise, family history, etc. But smoking. Hypertension, yes. You know, if you went out to your car right now and said, gee, it's supposed to have 30 pounds in pressure inside the tire, and put it 60 in there and kept it at 60, what do you think is going to happen to the tire? It's going to wear out sooner, right? So high blood pressure that's not controlled is going to make your arteries appear like that picture I showed you. Diabetes, unfortunately, yes. Diabetes is an epidemic in this country and in the world. We don't know too much about it. I just saw an article a couple of days ago about a new artificial pancreas, you know, like an artificial kidney. Doesn't that sound cool? But it was only 10 patients, but they did pretty well. So one of these days we'll have an answer, but in my career of more than 30 years of medicine, we've been looking for that answer, and we still don't have anything but very sophisticated insulin pumps and so forth. But diabetes, for some reason or other we don't understand, wears your arteries out. So a smoking male diabetic who's getting older, overweight, is going to have hardening of the arteries, okay? And other organ involvement, yes, that's why we're having the screening program on Saturday. It's not just to find out about people who can't walk, it's to find out because people who have plaques in their legs, have them in their hearts, their heads, stroke, heart attack, all over risk factors. And a key to that discovery can be poor leg function, claudication. Any questions so far? So, What does the doctor do next after he's done this long history? He does an examination. And the examination is very simple. It starts with the age-old detection of pulses. We all have certain areas in our body where the blood vessels are close to the surface and we can feel pulses. And we go over the pulses in the groin, knees, ankles, and down to the toes. In the upper extremity, the arms, we go to wrists and so forth. We're all familiar with a nurse taking our pulse. In this case, we're not just interested in the rate, because when the nurse takes your pulse at the bedside or the doctor's office, they're not really interested in whether it's there or not, because in the wrist, the artery is virtually always okay. They're interested in the rate, but in the legs, we're interested in presence or absence. Someone who has significantly blocked arteries doesn't have any pulses you can feel with your fingers, okay? And so we take the pulses. Bruits and thrills, you'll see the doctor take out his stethoscope and he starts listening to your neck, groin, heart, and so forth. We all know that you listen for heart murmurs, but arteries have murmurs too. They're called bruits. In other words, an artery that's wide open, blood goes through it just like down a pipe, okay? No, not making no noise at all. But if a plaque is getting there, it makes a whistle, just like if you took a little tube, a little wooden tube and put a narrowing in it, you'd have a whistle. So we hear a little noise we call bruit. So the doctor will say, I hear a bruit in your carotid artery in your neck, possible risk of stroke. I hear a bruit in your groin, meaning he's hearing a little whoosh, whoosh, whoosh sound because the blood is going around an obstruction, making a little vibration that he can pick up. So he'll listen. You're wondering, what, people listen to my heart before. Why are they listening down behind my knee? That's what for. Where were we? Oh, the extremity. Well, basically the simple rule is that a leg that doesn't have much blood in it is cold, pale, okay? Just like if someone faints, what happens to them? They look pale, and sometimes they look deadly, almost so, okay? Blanching with elevation. Well, we simply take the patient's leg and lift it up. So if this is the bed, we lift the leg up like this and look at the foot. Sometimes you don't have to do that. The foot is already pale. We'll see a picture of that in a minute. But already pale compared to the other side. Now when we lift it up, the good side stays nice and pink. The other side turns white as a sheet. Okay, that's a sign. So he's looking for pulses, then he's going to lift your foot up, put it down. Dependent rubor is the opposite of that. People will come in and they say, when I have this pain at night, I hang my foot over the side of the bed and I can get some sleep. But I didn't think it was circulation because when I look at my foot when it's been hanging over the side of the bed, it's bright red. It must have a lot of color in it. And it does have a lot of color in it, but very little blood, because when the artery goes up and gets pale up here, and now it goes down, now blood goes down and pools in there. It can't get out. The pulse, the feeding of the heart isn't enough, and so it just fills up. It looks beet red. It doesn't look normal. It's not nice and pink. It looks kind of, like cherry juice, something like that color. That's called dependent rubor. The color and temperature, of course, we already talked about that, but the human finger can feel a temperature difference of 3 degrees Fahrenheit. Pretty accurate, just 3 degrees. You can tell the difference between something cold and something a little colder. So if your leg has poor circulation, just the temperature of it to someone who's feeling it may be slightly lower than the normal. And of course, we talked about ulcers, gangrene, cyanosis. We'll talk more about that. Ulcers are a breakdown of the skin. Gangrene, we'll see a picture of shortly. You don't want to look at that for too long. And then cyanosis, which is blue. In other words, just the oxygen level in the blood is so low that the blood is no longer red. It's kind of blue, like the veins in your hand are blue. Right? Well, the color of the arteries in color of the blood in your arteries is bright red. So as blood loses oxygen, it turns blue. And motor or sensory loss is a late change. In other words, if my nerves go without oxygen for a long period of time in the arm and the leg, they eventually stop working. So you can't move, okay? You can't feel. Now, your brain's a lot more sensitive than your toes for most people. So your brain goes out without oxygen just for a minute or so, it's not very good news. But you can go for quite a while with poor oxygen levels to your toes. So this is kind of an example of what your doctor is going to be looking for. You see this foot and that foot? They're markedly different color. This happened to be in a 21-year-old Stanford Olympic swimmer. and said he'd seen everybody, because when he swam, his leg would cramp up. He was swimming miles a day, and his coach said, well, for God's sake, you get some cramps. So he goes to the sports therapist and all that stuff. But it was consistent. He would then get it, not just swimming, but walking. His right leg, not his left. Remember, the right leg right here is the pink one. This is the pale one. Would cramp up when he walked just from his dorm over to the exercise area. And yet he saw doctor after doctor after doctor who didn't, in this 21-year-old guy, pick up the fact that he had no pulses in his leg. Because you don't generally feel for pulses in a 21-year-old who comes in. So the abnormality here, and what fooled the doctors too, was when he sat on the examining table with his feet hanging down, which is the position this is in, his right foot, the symptomatic one, the one you got pain in and the cramps in the leg, was that color. And this is the asymptomatic normal leg. Okay? So the reason this one is looking that way, it's normal. That's the way if we look when you hang them down over the side of the bed. They don't look like this, that cherry red, abnormally red. But it looks like it has a lot of blood in it, and it does. It's just that it's not the right color. Now this is another one that will fool you. And you might say, what the heck is this thing? You go to your podiatrist, maybe your dermatologist, maybe your friendly family doctor. Say, well, I don't know what the heck it is. Does it bother you? Yeah, you know what? That toe at night wakes me up in the middle of the night. It's sore. And that's what causes the pain. Now, what do you do for relief of the pain? These are classic medical school questions. I put my foot down, and it feels better in a couple minutes, and I go back to sleep. So that's a little teeny early ulceration from somebody who's got poor blood supply. Just looks like that. Looks like you could have stepped on something, looks like a little rash, but the symptoms of pain, relief, and so forth are pretty classic. This is the same guy somewhat later. The diagnosis hasn't been made yet. He's gone on. Now he has 3 toes involved. Again, with this purplish discoloration, pain at elevation, not during the day, puts it down, feels better. Okay? So the diagnosis has not been established now, and months went by. Now this is his other foot, and this is early gangrene. This is about to become early gangrene. And the interesting thing about this guy, he still has normal pulses. Pulses are not gone like they normally should be to see this kind of foot. The reason is he is showering little pieces of plaque from his aorta. This is the end stage of that foot. Now, by now, a long time has gone by, and this is the first time I saw him. I got the pictures because his dermatologist was carefully photographing the toes as one by one by one they developed these problems. So finally he came to see me with his toes looking like that, but still with good pulses. So these diagnoses are it's kind of fun to be a vascular specialist because sometimes there's really, kind of a detective story behind the whole thing. So that's gangrene. This is another kind of situation that can be vexing. This is a heel ulceration. It's in a diabetic, non-healing wound. Comes to the wound clinic after a couple years of having this thing, and she's been through every podiatric support and off-lifting and so forth and so on, and this thing will just not heal. She's a diabetic, and she has neuropathy, which means the nerves have been injured by the diabetes, so she can't feel. Instead of feeling pain, she feels an uncomfortable, what we call neuropathy, which is a very vexing thing. It feels a lot like, I think, I don't have it, but it feels a lot like when your leg falls asleep in the movies, and you get to go, it was a great movie, and didn't move an inch, you're scared to death. Now you get up to walk, and your leg is just numb and tingly, and of course it goes away. But this is what diabetics feel all the time, kind of a tingly, very irritating thing. So she's not able to feel pain, but she does feel this sensation. So this too went undiagnosed. She has no pulses, okay? No pulses at all. And it should have been taken care of by restoring flow for some time. So we'll take a little break here before we go on to things. Do you mind if I use do we need a volunteer? Would you mind coming up here and let me?
Sure.
So I'll just it's a little bit dark here. Can you see me pretty well?
Yes.
Do you mind if I take your arm? I'm going to pretend my hand is a blood pressure cuff.
Okay.
Okay? So put out both of your hands for a minute. Make sure you don't already have troubles. So you can see he's got nice pink warm hands, right? So now I'm going to pretend like my hand is a plaque. So I want you to open and close your hands, both of them.
Both.
Open and squeeze. So what I'm doing is having him exercise just like a person is going to, so he's going to claudicate in his hand, because this is the same feeling you get with a blood pressure cuff. Remember how, Jesus, what's that? So I'm kind of doing that, but I'm not pressing on his whole arm, just on the artery. So stop for a minute. You kind of see what's going on?
Uh-huh. One side is pinkier than the
Okay,
other.
now keep it up if you can. Just keep
Squeezing?
on the squeezing and release. So we're asking him to exercise these muscles and the little muscles in the hand too, without normal blood supply. I'm not completely blocking the artery like they do with the blood pressure cuff, but I'm coming close. So how does it feel?
A little bit tight here.
Come on. How does it feel, really?
Yeah, that's
How's your hand feel?
fine.
Well, all right. You see the way his fingers are kind of drawn up a little bit on that side? Okay, so anyway, pale. This is normal, right? It's still normal. This is what is happening. Now watch what happens when, hold your hands out again so everybody can see. Now I'm going to release the circulation. Now that's just like the person who's lying in bed at night. Oh, keep it out, keep it out. It's fun to watch. And foot gets pale, cool, just like that. And then when he puts his foot down, it turns red. Now remember that foot I showed you that was the abnormal one, but it had blood in it. So that's why I can fool you. Thanks a million.
Okay.
But you didn't have the right symptoms. Okay, so that's feeling the pulses. Now, the doctor, and almost all doctors have these things now when they're taking care of adults, will now proceed, because not everybody can feel pulses. You know, some people can feel one easily, no matter what. Other people can't feel pulses in a heart, a beating heart. They'd say, oh, I can't feel anything. And some people can feel a pulse in a turnip. So it's a little, it's a subjective thing. And even though you've learned it, so we have now a Doppler, and I'm going to show you how a Doppler works, because they'll whip this thing out and use it, and it's a little noisy, but basically it's a electronic stethoscope. Remember, a stethoscope is one you put in your ears and you don't have any electronics. It's just, you're just listening to the heart or the arteries. This is electronic. So he turns this thing on and puts it over the little artery. Maybe that's a little too loud. You can't see the instrument? Okay. It's just this little pencil-like thing. Can you hear that okay? So that's like listening for a heart murmur in your heart, only you can't listen to these little teeny arteries at your wrist. So that gives him an idea that even though he can't feel, he can use the Doppler, and there's a pretty good signal there. We call it a Doppler signal. Okay, now, if the artery were obstructed, if there weren't much flow in it, here's what it would sound like. I'm going to... I don't know if you can tell the difference. Now listen. Okay, so he can tell by listening, if he's experienced, you know, that this is an abnormal signal or a normal signal, just like you can tell whether it's a heart murmur that comes from one spot or another. But more importantly, yeah, that's what it sounds like in the office. There's a little speaker thing here. Okay, although there's other ones too. So he'll do that, and then he'll take a blood pressure cuff, and instead of putting it on your arm, okay, he'll now put it on your ankle. And he'll use this, I'll call him in about 45 minutes. And he'll use this to get the pressure in your wrist, pressure in your ankle, okay? So he takes a blood pressure cuff, or just an ordinary one, puts it around your ankle, uses this, gets a signal, and he blows up the blood pressure cuff. Let's pretend this is my ankle. And the signal will go away at a certain point. He then looks at the cuff and says, okay, that's 120. Let's say it's 120. Okay, that's your pressure at your ankle. And then he will take your blood pressure in your artery, in your arm, and compare the two. And they should be the same. So he can take a pressure in your ankle or your wrist or someplace where you don't use a stethoscope, and then compare it to the brachial artery pressure here in your arm, and then he gets a feeling of what's going on. For instance, if your blood pressure here in your arm is 120 and your ankle is 120, that is normal. Okay, but in most people that have blocked arteries, the blood pressure in your ankle will be much less than that. So Saturday, we're going to have a program here where everybody can come in and we'll measure the pressure in your ankle and in your arm and compare the two. And if they're abnormal, we're going to send you to your doctor saying there may be vascular disease in your legs, and you better check out the heart, neck, brain, and so forth. It's very simple to do, just a little blood pressure thing. If it's abnormal, it can be a big key to living forever. So that's a Doppler, and it's one of the non-invasive tests that doctors will do to quantify what's going on. They may do treadmills. They may put you on a treadmill and say walk for a certain distance, and they'll see exactly how far you can get, and they'll take the pressure in your ankle before you start and afterwards. By that, we get a lot of information about how disabled you are, where the blockages are, how serious they are, and what we can do about them. Anyway, these are arteriograms. Your doctor will talk about that because this is the gold standard in trying to figure out what's wrong with you. If we take, these are x-rays. If we take x-rays of your belly, we just see gas and some bone in your back and stuff like that. We don't see any arteries. Arteries don't show up on ordinary x-rays. So we take an x-ray of your chest, for instance, we see the outline of the heart, but not the circulation to the heart. So in order to see the arteries, we fill them with dye, which is this white stuff. It's not really dye, it's liquid, looks like water actually, but it travels through the system and produces an image, and we take basically moving films of it. It's called an angiogram. So if you came into the hospital across the street right now with a heart attack, you would go right directly to the cath lab and have x-rays like this, angiograms taken of your heart. They'd see where the blockages were, and hopefully they would fix them immediately with a balloon. If you came into me with your legs, eventually you get around to having angiograms like this. We do have CT scans that do it, MR scans that do it, but this is the gold standard, the traditional angiogram. And the other ones are hard to read, so I brought these along to show you what we might find. This is the person who has no circulation to the right leg. This is the aorta coming down to the belly button, where we looked before. The belly button is supposed to be two big branches, one to the left, one to the right, and it's missing. The one on the right leg is filled with clot and plaque, and no circulation is getting past that. Down below here, we'll see another example where these arteries, see where they're getting kind of moth-eaten and so forth. That's early plaque in the thigh. And down below here, the arteries are completely blocked. The main artery from the groin to here is missing. This little thing here is what we call a collateral. A collateral is what Mother Nature, what God puts in there. It's a sort of Mother Nature's bypass to keep the leg alive even though this main artery is gone. So the main artery is gone, but right here, see? The main artery is there, and these little blood vessels are filling it. So people say, how come if I have a 100% blockage in my thigh, I still have a leg? And the answer is, over a period of time, collaterals can form. Here's another example. See the main artery come down, and it's missing. But right around it is a little collateral that God put in there to help save your leg until the vascular surgeon came around. Okay? So those are collaterals. Here's another example. Complete example of blockage in the lower leg, but right around here in the knee, it fills up again. And this is the concept we're talking about. So your doctor will say, no, hopefully you'll say, no, we don't have to do surgery. We don't have to do anything except change your lifestyle. Stop smoking, lose some weight, and start exercising, because the exercise will develop these collaterals. This is the normal system of an artery, belly button, right, left. These little branches are here and here and here and here, little teeny branches going off to various spots, but they're small. As plaque forms, remember that we just saw a blockage on the right side? As plaque forms, these arteries, compare this one and this one and this one and that one, these arteries are getting bigger. Because as the plaque forms, pressure changes and the body can actually form its own bypasses. So the best vascular surgeon keeps you out of the operating room, okay? He tries to get some other solution to your problems. It might be pills, but more commonly it's exercise, dietary change, and so forth. And that's what he's trying to do. People look to me like, what do you mean? Why don't you just fix it? It's total blockage in the artery, for heaven's sake, you know? That's what we do for a living. I say, yeah, but we don't want to do it unless it's necessary, because it can cause troubles. So the concept is collateral circulation, which, if encouraged and not prevented by your lifestyle, can be pretty important. So this is another example of how these things can get absolutely huge. So a total blockage of the main artery around the belly button can be dealt with by great big collaterals. Does anybody not understand that? Because that's what we're trying to do with folks who already have troubles. We're trying to keep them out of the operating room, off the operating table, and encourage the body to heal itself. So what do we do for plaque? The oldest operation was take it out, and it still is in certain areas like the neck. This is a plaque in that same aorta right around the belly button. Big yellow plaque, patient can't walk. We used to have to go in, we'd open it up with incisions and actually take the plaque out. Remember, it doesn't involve the entire artery. It just involves the inner part of the artery. Okay, so we can clean it out, sew it up, and the artery is back to where you were when you were a couple days old. That's called endarterectomy. Here's an example of a big plaque sitting there. See it right there on the side? And we take it out. This is what it looks like. This is not the artery. The artery is still in the patient. Okay? This is the plaque we took out of the artery. See how ugly it looks? It looks like a big tooth in a dinosaur or something. Another example, I think this is another plaque we took out of the same area. Remember, the artery is in the patient. Okay? We didn't replace it. We didn't put a tube in there. This is just an endarterectomy, and that's the way it looks. Clot, yellow plaque, bony-like stuff.
What is that, about the size of a pencil?
No, that's about the size of your thumb.
I mean, what you took out is.
What that is. Yeah. Here's another example of how we do it. This is a groin artery, and it's been opened up in a slit like here. Okay? This is the clamp. You see this shining stuff here? That's the good part of the artery. This is the plaque on the inside, and there's a plane, a space between the wall of the artery and this plaque. That's what this tool is in. It's going to separate this and take out that plaque and leave behind the artery. That's the way it looked with the artery out. Here's before. Okay? Here's after. Bypasses. We all heard about bypasses. Most of the time, you're talking about bypasses in the heart, but we can bypass any place. That's what the plumber does when they say, well, let's repipe your place. He doesn't mean he's going to tear all the pipes out of everywhere. He's going to go out to the pressure head at the street or wherever it is that's good. He'll attach a new pipe there. He won't take the old ones out. He'll run it around all the bad pipes and put it down someplace lower. So here's what one of those grafts looks like. This is up in the belly. Okay? It's made out of Dacron. It comes off the shelf. We have various sizes, just like shoe sizes. We pick out the one that fits you best. And we take out the artery, don't ream it out this time, and clean it out. Here's a long bypass. Okay, we rarely do these anymore. But we've taken a vein of your own leg, which comes from these little holes. We attach it up here in the groin, run it through the tunnels, and attach it down here. So this is an example of that. More arteries. I think we're running out of time and we want to have a couple more questions. Here's a bypass that's sewn in below the knee. This is an artificial tube. The artery itself is all blocked, so we do a bypass. Oh, here's something that actually can produce things. This is an ulcer of a diabetic heel. That was long. Remember the one we showed early on? This is that same lady, and this is after we did the bypass and healed it up. So I think we'll just go through these. These are all tools. So Dr. Jane is going to talk a little bit about that. And this is my wife telling me it's time to stop talking about surgery, get on with something else. Okay.
I have actually two questions. Is diet very much a part of this disease, or is this just hereditary?
Well, it's not number one. It's way down the list.
Is it reversible?
No.
So once you
There are some people in the world that will argue with that, but the best we can do with diet, stopping smoking, and so forth is to stabilize it. The biggest problem in most people is age. So if you can arrange not to get older, What's your second question?
The other was, once you have a diagnosis of this, or you feel that you're starting it, how long does it take for it to take its course and really become a problem?
Remember I said it doesn't happen quickly, like your heart. It happens really quite slowly over a period of time. Most people that I see with significant problems, the history started 3 or 4 years ago. It just took a long time to get serious enough to, using the 10-30 rule, to complain to your doctor about.
Doctor, I've got a blood pressure machine at home. Is there a way I could use that to self-diagnose the situation?
No, you can't use the machine. It's not accurate enough to help with your legs.
Okay, and I guess my symptoms would be I've got the heel has got a very white, hard spot on it, and I get leg cramps, and the only way I can get rid of them is straightening out my leg. Does that sound like it?
Yeah, it sounds like you should be checked out.
Okay, thank you.
Yeah.
For about the last 3 years, my mom's had a swelling in her legs. It's just one leg. It's numb, and it's pain. It wakes her up at nighttime. And when it gets bad, she stumbles. But it does have a pulse, and she's had it for about 3 years.
Well, if she has good pulses, then it's a problem that's not from her arterial circulation, but it could be the venous. It could be that blood's going down to her foot just fine, but not getting back out of the leg because she's had blood clots in the veins, or phlebitis is another word for it. And so that would be something the doctor would check out. But you start with the arteries. Make sure it's not arterial.
The only symptom the only symptom I seem to have that you talked about here is leg cramps, quite often and quite severe. I always thought that was strictly a muscular problem. Could that be a vascular problem?
Yes, it can be. Yes, it can be. Leg cramps, unfortunately, are something that happens to almost everybody once in a while, some people all the time. And if you complain to your doctor, what's the first thing he would do? The first thing he would do is check your circulation. Why? Not because it's the most likely thing, but it's the most serious thing. In other words, you're having cramps in your legs at night from poor circulation, you have a big problem. If you have cramps because the phase of the moon or the time of the, whatever it is, usually it's benign. But cramps from circulation, that's a big deal. So the first thing he does is go down to your legs, just like we were doing, feel for pulses, ask additional questions about claudication, how far can you walk, and so forth. Maybe he says, I don't feel any pulses. So I'll send you to a vascular specialist or a vascular laboratory to do a careful analysis of your circulation. But yeah, number one on your list, you complain of chest pain, what's the most important thing? Heart attack. Complain of pain in your head, what's the most important thing? Blood vessel bleeding. Complain of pain in your belly, same thing. Poor circulation to your intestines, that's the first thing. It's usually not the most common thing, but it's the one the doctor says, chest pain started this morning. So you having a heart attack? Cramps at night, every night, relieved by getting up to go to the bathroom? Maybe it's circulation. Check the pulses.
Okay, thank you.
If there is a certain percentage decline in the heart function activity, does that affect the strength of the legs when apparently the circulation and blood flow tests show okay, or is that another problem?
It's extremely rare for the legs to be affected by your heart output. You really have to have a bad heart. If your blood vessels in your legs are normal and you're having trouble, it's almost unheard of that it's your heart problem.
Blood activity is minimized by, say, 30%. Would that have an effect on the strength?
No, not at 30%. It'd have to be down like 10% or less.
So then it's another problem, not the heart?
Yes.
Okay,